Good afternoon, respected seniors and dear colleagues. Today, Department of Medicine Unit 2 is going to present the clinical combined round. This patient, 24-year-old young male, presented to the OPD. He was referred from a tertiary care hospital in Delhi with the diagnosis of a cardiac illness, and subsequently he developed skin lesions. And we evaluated and diagnosed and treated the patient. So, Dr. Vaidyanath, Junior Resident, Infectious Disease, will discuss the case, and Dr. Adarsh, Senior Resident in Infectious Disease, will discuss the review of literature, followed by concluding remarks by Dr. Upender Betha, Associate Professor, Medicine Unit 2. So, Dr. Vaidyanath Gupta.
Respected faculty members and my dear colleagues, myself Dr. Badnath, I'll be discussing the case followed by discussion by Dr. Adarsh. So, here is 24-year-old male unmarried resident of Gurugram, supervisor in a company with no prior comorbidities, presented to AIIMS on 6th of Feb with complaint of fever for 3 months, headache for 3 months, abnormal body movement, which was 2 episodes, first one in November and second one in February, with multiple joint pains for 2 months and multiple skin lesions for 2 months, and generalized weakness in the course of illness he has for 2 months. So he was apparently well 3 months ago. Then he developed fever. First episode in month of November. That was high grade, associated with chills and rigor. Relieved on medication. After that he had fever every 2 to 3 days, and as such there was no any diurnal variation. He had, after 1 week of onset of fever, he had one episode of generalized onset tonic-clonic movement in all four limbs. It was associated with deviation of angle of mouth, uprolling of eyeballs, frothing from the mouth, no bladder and bowel involvement. It lasted for 5 to 7 minutes, followed by drowsiness for 1.5 hours. Most likely it was a seizure. For that, on that day, he was taken to some local hospital where some symptomatic management was done, and after that he was discharged. So after that episode of seizure, patient started having complaint of headache. That was gradual onset, moderate to severe intensity. It was bilateral, gradually progressive. As such, no aggravating factor, and relief on medication. After that, he had 2 to 3 episodes daily, each lasting for around half an hour, and mostly associated with onset of fever. After that, he is ill from the month of November. In month of January, in starting, he developed multiple joint pains. Started with knee joint, involving mostly large joints that are bilateral knee, elbow, and wrist. It was symmetrical involvement, which was progressive, and aggravate on movement, relief with medication. There was no any association with swelling, redness, or morning stiffness of the joints involved. So, into the 2 months internal lease, patient has generalized weakness and loss of appetite. In month of January, patient visited GV Pant Hospital, where he was diagnosed with some cardiac disease and started on some drug and symptomatically managed for fever, headache, and joint pains. Then, in end of January, patient developed painful pruritic maculopapular skin rash at anterior aspect of right knee initially, that gradually progresses to trunk, back, face, bilateral upper and lower limb, including palms and soles in next 15 days. So, as such, he was taking symptomatic management from multiple local hospitals, but condition was deteriorating. So, he presented to AIIMS on 6th of Feb. In negative history, he has no any history of cough, chest pain, shortness of breath, or palpitation. No history of abdominal pain, vomiting, or jaundice. No any history other neurological findings like diplopia, speech difficulty, facial asymmetry, or altered mental status, or any bowel or blood habit. Though any history of travel to exotic places like cave, hilly areas, or outside India, and no any history of living with domestic animals, and no history of any recent vaccination. So, in past history, in March 2021, he has painful vesicular rash in left armpits and infraclavicular region, for which he took medication for 2 months. No similar complaint in the past, and also no history of any diabetes, hypertension, or any other chronic illness. No such positive findings in the family history or family history. In personal history, he is a non-smoker, non-alcoholic, no substance abuse, no history of blood transfusion, and no any allergy. He denied initially any of high risk behavior. Uh, At presentation on examination, he was conscious, oriented to time, place, and person. GCS was E4V5M6. Pulse rate was 108 and BP 110 by 82 mmHg. Respiration rate 18 and saturation of 99. Pallor was present, but no actress, cyanosis, clubbing, and edema. Generalized lymphadenopathy was present. It was present in bilateral cervical level 1 and 3, that was multiple, discrete, non-tender, rubbery, movable, and largest being 1.5 centimeter. Bilateral axillary as well as inguinal lymph nodes were also there, largest being size of 1.5 centimeter. On further examination, skin, there was light brown maculopapular skin lesions in varying phases of evolution, that was crusted papules, plaques over chest, back, face, soles, as well as palms. So we can see the lesions that will present on face, chest, back, palms, as well chest, back, palms, as well as soles. So coming to systemic examination, on abdominal examination, oral cavity, it has poor oral hygiene. Abdomen was soft, non-tender. Liver was palpable, 4 centimeter below costal margin. Span was 16 centimeter. Spleen was not palpable. Coming to the next system of involvement, central nervous system, normal higher mental function was normal. On cranial nerve examination, he has visual acuity of 6 by 9 in right eye, but finger counting at 3 meter only in the left eye. Color vision was normal in right eye. Pupils were bilateral, normal size, normal direct and consensual reflex. On fundus examination, further, there we can see here, we can clearly see the disc as well as vessels in the right eye, but in left eye, media was hazy and also cells were present. So, it was suggestive of a panuveitis, iritis, as well as chorioretinitis. Further, other cranial nerves were normal, motor, normal bulk in bilateral upper and lower limb, normal tone also, and power was symmetrical weakness in upper as well as lower limb, that is 4 by 5 in the upper limbs and 3 by 5 in the lower limb. Sensory system, primary as well as cortical sensation were normal in all dermatomes. Reflexes was normal with 2 plus in all the joints tested. Plantar was bilateral flexor response with no any cerebellar sign as well as no meningeal signs. So respiratory system as well as cardiovascular system, on clinical examination, there was all were within normal limits. On musculoskeletal examination, there was mild tenderness along the bilateral knee joints as well as elbow joints, but there was no swelling, redness, raised temperature, or decreased range of motion, suggestive likely of arthralgia, not any arthritis. So, based on the history as well as clinical examination, summarizing the case, we have 25-year-old male with fever, multiple maculopapular skin lesions, multiple joint pain, headache, 2 episodes of GCS. Then he has on examination hepatomegaly, generalized lymphadenopathy, and decreased visual acuity as well as left eye panuveitis. So a patient with these complaints, along with the on examination of skin, mostly suggestive of infective etiology. So we made a differential diagnosis of maybe disseminated fungal infection, including chronic meningitis, can be due to histoplasmosis or cryptococcosis. These features may suggest towards brucellosis, syphilis, systemic vasculitis with CNS involvement. Underlying retroviral disease is likely, and least probably disseminated tuberculosis. So I'll just discuss in brief that what were favor and what were against in of this differential diagnosis. So in disseminated fungal infections, there were fever, lymphadenopathy, hepatomegaly, skin lesions, CNS involvement, as well as eye involvement. But point against were there was no any history of exposure that travel or some not was there. Usually histoplasmosis commonly involved respiratory involvement, but there was no any respiratory symptoms. And at that time, immunocompromised status was not known. So brucellosis. These all features can be present, a fever, generalized lymphadenopathy, arthralgia, hepatomegaly, skin lesions, neurological involvement. Uveitis can be present, but it is a rare involvement in brucella. There is no any history of having domestic animals and no any history of intake of raw meat or dairy products, raw dairy products. Syphilis, he has fever, generalized lymphadenopathy, arthralgia, hepatomegaly, skin lesions, neurological involvement, as well as uveitis, but immunocompromised status due to any disease was not known, and he had denied high risk behavior. So, on systemic vasculitic, fever, arthralgia, uveitis, or neurological involvement can be present, but skin lesions not typical of vasculitis were more suggestive of infective etiology, no respiratory or renal involvement, and there was generalized lymphadenopathy, which is present very uncommon in vasculitis syndrome. Disseminated tuberculosis, all these features, fever, generalized lymphadenopathy, arthralgia, hepatomegaly, neurological involvement, as well as uveitis, although it is uncommon, but skin lesions were not typical of TB, and also there is, if there is disseminated, patient might have a history of pulmonary tuberculosis, but this patient doesn't have. So on patient was admitted for these complaints, and further evaluation was done. So on for initial investigations, we can see patient have anemia, some hyponatremia, as well as transaminitis. So on further course of treatment, that anemia was persistent, but transaminitis was on resolving trend. Blood culture was sent that has grown staph hominis. So when blood culture was flagged, and after that isolation was done, that time treatment was also started for bloodstream infection and bacteremia. On urine examination, it was within normal limits, and inflammatory markers CRP, LDH were raised. So further imaging studies was done. I'd like to invite Dr. Mohit. He will just discuss the imaging studies.
Thank you, Dr. Badna. Good afternoon, everyone. I'd like to discuss the imaging finding of this case. So we did a CCT head, neck, chest, and abdomen on 10th of Feb for this patient, and the CCT head was completely normal. And in the chest and abdomen, the findings were there was enlarged cervical lymph nodes, parietal axillary lymph nodes, there were retroperitoneal lymph nodes, as well as AP window lymph node in the mediastinum. And apart from that, another finding was there was presence of hepatomegaly. And another incidental finding was there was a lytic lesion in the left coracoid process. So this spectrum of finding is suggestive of an infective etiology, most common being a tuberculous etiology. However, the skin lesions are not favoring tuberculous etiology, and similar findings can also be seen in other infections that we have enlisted before, the brucellosis, histoplasmosis, and syphilis. So these are non-specific findings which suggest an infective etiology. Thank you, Dr. Badina.
Thank you.
Other uncommon etiology would be a lymphoma, but in this case, with the clinical setting, we would like to keep an infective etiology higher up.
Thank you, Dr. Mohit. So on further evaluation, as he had presented with some diagnosed with cardiac ailment outside hospital, so we had done 2D echo that has shown global hypokinesia, LV dilate, with severe LV dysfunction that was 25 to 30% ejection fraction, mild MR, TR, and AR with moderate PAH. So on further, as we were suspecting with CNS involvement, CSF was done that shows leukocytes of 10, 100% lymphocytes. As such, no any other findings were positive, except mild protein was elevated towards the higher side of the normal, that was 61. Other than that, AB gene expert for TB was negative, gram stain for bacterial also was negative, India-ing cryptococcal antigen, galactomannan, as well as VDRL was negative in CSF. Then also for serum studies, we did that HIV was positive with CD4 137, HBs AG was negative, anti-HBC was negative. For other, after getting the retropositive status, we further evaluated for other co-infections. RK13 was negative, serum cryptococcal antigen was negative, brucella SAT was negative, and as well as for toxoplasma IgM ELISA was negative. With some lower down differentials, we had kept vasculitis. The DNA shows 1 plus spectral pattern, but it is very non-specific. Others, ANCA was negative, RA factor was non-reactive, ferritin was elevated, B12 folate was in normal limits. So after the retropositive, although initially we had tried to examine his genitalia, but he was very reluctant, and also he had denied multiple times regarding the sexual history. But taking confidence in of the patient, we insisted to tell about his sexual history, and he revealed that he has high risk sexual behavior in last 4 years, and also on genital there was one ulcer on the ventral shaft with penless, circular, around 1 centimeter in diameter, raised border with induration and smooth base. So also biopsy of skin was done with okay. So further then serum VDRL also comes positive with titer of 1:128, and for confirmation a treponemal test should be done. That TPHA was also positive with one titer of 1:160. Meanwhile, a skin biopsy was also sent, which report came later that shows epithelioid cell granulomas with mixed inflammatory granulomatous response. So these were the skin biopsy, but it was just suggestive of chronic disease. Not any specific fungal infection was revealed. So concluding all these findings, history, examination, as well as the investigations, we have a final diagnosis of syphilis, that is primary, secondary, as Shankar is present, secondary because all these manifestations are present. He has ocular syphilis as well as neurosyphilis. He has underlying retroviral disease with CD4 of 137, WHO clinical stage 4, severe LV dysfunction, syphilitic heart involvement is this type of involvement is uncommon in syphilis, mostly otitis or something happens. So it mostly due to HIV related cardiomyopathy, and he has anemia of chronic disease. So patient was diagnosed with syphilis and all the full diagnosis. Then treatment was started. Initially, he was given amoxicillin and teicoplanin for that bacteremia, for which patient has initially some response. But after confirmation of syphilis, we treated him with ceftriaxone. And then levetiracetam was started for seizures, and then retro disease was treated with highly active antiretroviral treatment, and PCP prophylaxis was given along with him. So after 20 days of treatment, we followed up the patient. That visual acuity has improved with left eye visual acuity of 6/18 from finger counting at 3 meter, but echo parameters is similar as previously with reduced ejection fraction. Further, skin lesions that are in healing stage in the last follow-up, that is 2 days ago only. And so for further discussion part, I'd like to invite Dr. Others.
Thank you, Baidnath, for the case presentation. So I would like to begin the discussion of this case of syphilis with these words by Professor Dr. William Osler, that he who knows syphilis knows medicine. So that is evident by the florid manifestations of this disease which can have on a person, as we have seen in this case. So my discussion will focus around the changing epidemiology of syphilis, some of the atypical presentations which we have seen, the prognosis in case of ocular syphilis, diagnostic dilemma in case of neurosyphilis, alternate treatment options for syphilis, and finally a word on HIV and syphilis. So syphilis is an age-old disease. Most of us are known about the manifestations of the disease. However, we see a resurgence which is reported since the turn of the century worldwide. So data from India are limited. This I have quoted data from CDC regarding the number of cases in US of syphilis. We can see that after 2005-2010 period, there is a gradual increase in the number of cases of syphilis. And when compared to 2017, there has been a 13.3% increase in the total number of cases of syphilis in 2018. So here, what I mean to tell is that syphilis should be kept in mind in any person, especially a retroviral person who presents with compatible clinical manifestations. Now, one atypical feature which we have found in this patient was that the coexistence of primary and secondary syphilis lesions. So usually the classical teaching is that initially there is a primary syphilis which then heals, and then later after 2 to 6 weeks there is development of secondary syphilis. Here we have seen that the same person had both the lesions. So it is an uncommon manifestation of syphilis, and the concomitant existence of secondary and primary syphilis lesion is more likely to develop in HIV infected individuals. And this study shows that HIV infected patients with secondary syphilis, they present more frequently with concomitant genital ulcers. And also HIV infected patients with primary syphilis can have multiple ulcers compared to single ulcer in non-HIV patients. Now, this is a case series regarding the concomitant primary and secondary syphilis. Now, the reasons for such a presentation told are: one is a rapid progression of the disease from the primary to the secondary stage in HIV infected patient. And second reason is due to a delayed healing of the genital ulcer due to the immunocompromised state of the patient. Now, our next concern was ocular syphilis. The patient had ocular syphilis, and we were concerned about the vision loss in this patient because an untreated ocular syphilis can result in permanent visual loss. So, this study from South India has analyzed the clinical manifestations and outcomes of ocular syphilis, where they included 20 patients. 19 of them received crystalline penicillin, and 2 patients they received an additional course of doxycycline for 2 weeks. Now, this study quoted that majority of the patients, the lesions of ocular syphilis responded well to 14 days course of IV penicillin. Now, this study, it has specifically looked into the factors which guide the prognosis of ocular syphilis. So, it has mentioned that having ocular symptoms for more than 28 days before diagnosis was associated with the poor prognosis. As in our patient, the patient had all other symptoms of a very long duration, around 3 months, but the ocular symptom, it was of short duration. We have diagnosed it from the ward. So, he had a significant improvement in his vision from the finger counting at 3 meters to around 6/18 on his first follow. Now, the next concerning thing in our patient was the doubt whether the patient had a neurosyphilis or not. So, I would like to quote these words by Dr. J. Stokes, who was a pioneer in syphilis, that the frequency of neurosyphilis in general practice depends to a large extent on the thoroughness of search for the signs of neural involvement and the frequency of CSF examination. So, here I have quoted the diagnostic criteria for neurosyphilis as per the CDC. So, we can have a confirmed neurosyphilis and a probable neurosyphilis. So, our patient had neurological symptoms in the form of chronic headache and seizures. He had neurological signs. He had involvement of the optic nerve as well as he had motor weakness. CSF study had revealed pleocytosis. However, pleocytosis is also a feature of an HIV infection alone in the absence of any other opportunistic infection. The CSF VDRL was negative, but we must note that CSF VDRL sensitivity, the maximum is around 80%. He had a positive serum troponemal and non-troponemal tests. Although imaging is not a part of criteria, the imaging which we done didn't reveal any features of chronic meningitis or anything to suggest neurosyphilis in the patient. An MRI couldn't be done because of logistic reasons. So, I would like to tell that neurosyphilis is so much confusing to the clinicians. But however, the treatment of ocular syphilis and neurosyphilis are the same. So, the patient had received a treatment which would also be beneficial for neurosyphilis if at all he had the same. So, we have diagnosed that the patient had a probable neurosyphilis based on the criteria. And we know that since centuries, penicillin is the drug of choice for syphilis. Various forms of penicillin are used for the various stages of syphilis. Now, we have treated our patient with ceftriaxone. So, what is the evidence behind this? Is ceftriaxone a good alternative? So, this was a study, penicillin versus ceftriaxone in case of early syphilis. This was a randomized open label control study between November 2013 and 15. And this study has shown that ceftriaxone regimen was non-inferior to the benzyl penicillin G regimen in non-pregnant immunocompetent patients with early syphilis. So, now what about in neurosyphilis? So, we have got a recent study in Lancet 2021, a retrospective multicenter cohort study which has compared ceftriaxone and benzyl penicillin in treatment of neurosyphilis. It has also shown that ceftriaxone is similarly effective to benzyl penicillin for the treatment of neurosyphilis. Now, we have the meta-analysis of ceftriaxone compared with penicillin, which included 7 RCTs involving 281 participants. So, this is the forest plot which compares the 3-month response, 6-month response, the relapse rate, the serofast rate, the treatment failure, and 12-month response rate. So, we see that the results are in favor of both, like there is no significant difference between ceftriaxone and penicillin. So no significant difference in the 3-month, 6-month, 12-month response rate as well as the relapse, serofluorescent failure rate. So ceftriaxone is as efficient as penicillin in treatment. And this is the CDC recommendation. Although the CDC has given ceftriaxone as a second alternative in the treatment of primary and secondary syphilis, ceftriaxone can be used in the treatment of neurosyphilis, ocular syphilis as well, owing to its good CSF and ocular penetration. And finally, I would like to tell that syphilis in an HIV patient is definitely a dangerous combination. So HIV patients with early syphilis have an increased risk of neurological complications. However, the treatment regimens for syphilis in an HIV patient is same as that for a non-HIV patient. But we need to have a frequent follow-up after therapy because there is a higher rate of serological non-response in patients with HIV. And regarding initiation of ART, HIV patients who are already on ART, who's being newly diagnosed with syphilis, will continue the ART as such. However, syphilis in patients with a concomitant HIV diagnosis, there is no recommendation to delay ART for any reason. So, ART can be initiated as soon as possible unless the patient have any other opportunistic infection. So, to conclude, syphilis is a great masquerader and it is re-emerging. Atypical features can be seen in HIV patients, and early recognition and treatment are essential to prevent permanent vision loss in ocular syphilis. And diagnosis of neurosyphilis requires a meticulous clinical examination. And ceftriaxone is as effective as penicillin in treatment. And finally, a good patient history combined with clinical skills are essential to reveal the secret history and hidden truths behind any disease. Thank you. I would like to call upon Dr. Upendra Beta sir for his.
Thank you, others. Good afternoon, everyone. Syphilis is a emerging disease, re-emerging, and we see very infrequently nowadays. But as you saw in graph, nowadays graph is coming up. That's the reason we thought we should present this, and we could make means aware for everyone. If syphilis as well as HIV combines, what happens actually? HIV with syphilis, we saw here that we get some atypical presentation, organ involvement as well as mucus or skin infestation becomes atypical, as well as neurological symptoms, particularly neurological symptoms become very early. Neurological symptoms, can develop in any stage of the syphilis, but particularly patient with HIV and syphilis, it develops little bit early or anytime it happens, and more means chances of neurological development even later part of the disease if patient will be not treated adequately. Second very important thing, in this patient we treated with ceftriaxone, particularly in view of means unavailability of penicillin or some risk of anaphylaxis reaction. That's the reason we treated ceftriaxone. This is not traditional recommendation, but on the basis of meta-analysis latest evidence, we treated with ceftriaxone. But two things, patient is very high risk on neurological relapse in this condition, because HIV itself actually makes it more means relapse, chances of relapse, and second we treated with ceftriaxone on the basis of latest evidence. That's the reason we have to follow with means serological testing, and we will see whether patient will have some relapse or not. This will means we have to see basically. And now I would like to take some comments or any means questions. Thank you.